Good afternoon, everyone. I am Linda Cobert, TMA's Research and Communications Director. I will be moderating this session, and I want to thank you for joining this webinar. Just a quick bit of housekeeping before we get started today. All phones will be muted throughout the presentation. However, we encourage you to ask questions. There's a chat box located at the bottom of your screen. You can type your questions into this box at any time throughout the presentation. We will have a question and answer period at the end of Dr. Sammartino's talk. This webinar is being recorded and will be live on our website for future reference. I would now like to introduce Mary McGowan, Executive Director of the Myositis Association.
Thank you, Linda. Good afternoon. Welcome to Myositis Association's webinar, Reproductive Health, Myositis, and Other Autoimmune Conditions. I'm Mary McGowan, Executive Director of the Myositis Association. For those of you who are not familiar with the Myositis Association, I want to spend just a few minutes providing a quick introduction to our organization. TMA is the leading international nonprofit association supporting those living with myositis, their care partners, and the medical community and researchers who care for them. We were founded by a patient, Eddie Curie, back in 1993. She began the organization with 12 patients, and since then we've grown to an international organization reaching thousands of patients and clinicians. Last year, the organization celebrated its 25th anniversary, and we are now an international collaborator of researchers advancing discoveries. Next slide, please. So what we do is really a five-pronged approach. We educate myositis patients, care partners, and clinicians. We support patients, care partners, and the medical community, and we advocate for research and policies that meet the needs of patients. We're located in Alexandria, just outside of Capitol Hill in Washington, D.C., so we're on Capitol Hill regularly. We fund critical research seeking understanding new treatments and ultimately a cure. And we, of course, increase awareness of myositis internationally with an emphasis on the medical community. Next slide, please. There are just a few more weeks left to sign up for this year's exciting annual patient conference. This year's program is jam-packed with exciting speakers, including global leaders in myositis research, pharmaceutical industry leaders running clinical trials in myositis, national experts in mental health, caregiver, and disability support services, and many more. Don't let this wonderful opportunity pass you by. To learn more, log on to myositis.org. Next slide, please. It is now my honor to introduce Dr. Lisa Sammartino. Dr. Sammartino is a rheumatologist at Hospital for Special Surgery in New York City. She maintains a busy clinical practice and participates in clinical research geared towards patients and rheumatologic conditions. She has a particular interest and expertise in reproductive issues in rheumatic disease patients, including contraception and pregnancy, and has presented on this topic to the TMA support group at Hospital for Special Surgery. With such an enlightening and important presentation, we wanted to share it with you today during this webinar. Thank you very much, and I will now turn it over to Dr. Sammartino.
Thank you, Mary, for the introduction, and thank you for inviting me to be a part of the webinar. I think it is a very important topic for patients with rheumatology disorders, and one that hasn't received enough attention in preceding years. So we're making an effort to change that by focusing on reproductive health issues for a number of different rheumatology disorders, including, of course, myositis. Next slide. So when I say reproductive health, these are the topics that I plan to cover today briefly: sexual health, contraception, fertility, pregnancy, breastfeeding, and menopause, really going through the reproductive lifespan. And that is because autoimmune diseases, including myositis, can impact each of these things, and in turn, these different stages of reproductive life can have an impact on underlying autoimmune disease. Next slide. Sexual health. Next slide. So The question is whether sexual health is an important issue for us to look into for people with autoimmune or connective tissue diseases. And there have been some studies that have looked at this in some of the more common rheumatology disorders, such as rheumatoid arthritis, lupus, scleroderma, and Sjogren's. There really are no studies that have looked at this specifically in myositis. However, it seems likely that these other patients' experiences are generalizable to patients with chronic rheumatic disease. And if one looks at the studies that have been published, 31 to 76% of patients with connective tissue disease or autoimmune disease say that they have experienced sexual problems, sexual difficulties, and diminished sex drive. And again, likely this is true for all of our rheumatic disorders. There are many causes that have been suggested for sexual issues in men and women with connective tissue disease, including the disease itself, medication effects, and then psychosocial factors that are indirect effects of disease and medication. Next slide. Sexual function, when we use that term, we are talking about really a variety of aspects of sexual health that can be impacted by disease. So sexual difficulties can include physical joint limitations that are related to arthritis, for example. Limited range of motion may lead to difficulty with certain positions. Patients may have painful sex or dyspareunia, often related to vaginal dryness or skin changes. And there may be disease-related weakness, joint pain, or stiffness that may also impact intercourse. In addition, many patients complain of a reduced sex drive or libido, and that can be related to disease or medications, and also to mood changes that are secondary, as we said, to disease and medication, such as depression, anxiety, or negative body image. Next slide, please. So there have been a number of studies that have demonstrated this negative effect on connective tissue disease patients in terms of sexual functioning. In lupus, there was one study with 106 lupus patients who were interviewed to find the impact of their illness perceptions on sexual functioning. And almost one half reported that just knowing that they had lupus had a negative influence on their sexual functioning, separate even from the physical limitations. So illness perceptions in this study were even more important than certain medical factors. Another study looked at 120 women with lupus and found decreased sexual function to be associated with a number of different psychological factors, including depression or psychological distress related to illness. And in fact, a further study looking at men with lupus found a higher rate of impotence. Next slide. In terms of medical professionals, this is an area that many physicians feel uncomfortable discussing with their patients. And this study that was done in the UK, I think, shows us that doctors, nurses, therapists are willing to engage and want to be helpful, but may not bring up these issues with patients themselves. So it seems it's often neglected. And in this survey of over 800 medical practitioners, 94% said they were unlikely to discuss sexual issues with patients. 86% said that they felt that staff members were really not trained for this or poorly trained. And yet 90% addressing sexual issues should be part of holistic care of the patients. Next slide. So what can we do to try and improve this? One is, of course, to get better control of disease by reducing pain, weakness, other associated symptoms, adjust medications if possible that might be giving side effects that are impacting sexual function or health. Physical therapy or even surgery in certain cases may be important, again, in improving one's physical condition. Use of lubricants for patients who suffer from dryness is actually been reported to be very significant for patients, especially those with Sjogren's. And then finally, address mood and body image issues. Talk with your rheumatologist, a psychiatrist, psychologist, or therapist. Sometimes a decrease in sex drive can come about because of depression related to ongoing chronic illness. And if one can improve that, then sex drive may improve as well. Next slide. I want to spend a few minutes now talking about contraception. Next slide, please. Because contraception in general is an important topic for women of reproductive age and for women with myositis or any other chronic illness. There are important concerns. First, the wish to avoid unplanned pregnancy for any reason, and that applies to any woman. But for women who are dealing with myositis, they may be on medications that could potentially cause birth defects if those medicines were continued through an unplanned pregnancy, for example, mycophenolate. In addition, presence of active disease at the start of or during pregnancy can impact the outcome of the pregnancy as well as the mother's health throughout the pregnancy. And overall, we know from many studies that the ideal situation is to wait for quiet disease before conceiving. That, of course, rests on a woman having access to safe and effective contraception. Next slide. So we have learned over the past 20 years or so that women with chronic medical problems are actually less, not more likely to use effective contraception, even though they have these other reasons that make it even more important for them to be protected. So this slide shows an observational study of reproductive aged women in Michigan, and they looked at insurance claims as well as patients' medical diagnoses. So this is what they call a database study. So they didn't actually speak to the patients. They looked at all of this data that was compiled in their computers and looked to see if women who had chronic medical conditions were more or less likely to be using what we call effective contraception, which is contraception that really is generally through a prescription, whether birth control pill or IUD or implant. So in terms of the outcome, 16% of the women whose data they looked at had one or more chronic conditions, and these chronic conditions included lupus and rheumatoid arthritis. Again, these are more common autoimmune diseases. Contraception prescriptions were given to 33% of women who had a chronic medical illness, and only 20% to women with lupus and RA, compared to 41% of those who did not have an underlying medical condition. So despite the greater risk, these women are less likely to get the effective contraception. Next slide. Effective contraception is underused by rheumatology patients in general. In one study, about 1/4 of patients who were on teratogenic drugs, that means drugs that can cause birth defects, were not using any form of contraception. And most of those, because this was a survey study where patients' input was asked for, most of those who were not using it were aware of the potential adverse effects of these drugs. One reason might be a lack of screening or counseling by MDs. Just as with sexual health, areas of contraception may not be discussed by rheumatologists. In one study of pediatric rheumatology physicians, they asked doctors why they were not bringing up some of these topics with their patients, and the major barrier was lack of time. But other factors that were mentioned included discomfort with the subject area and ambivalence about the role of a rheumatologist as opposed to a gynecologist in asking these questions. Next slide. But these are important questions to ask, and it's important for physicians, nurses, patients to think about not only using contraception, but using effective contraception. This is actually a chart from the CDC that is on their website, and it's just an easy way of showing how effective different forms of contraception are. And so, just to summarize, if you look at the top, what's called LARC, or long-acting reversible contraception. These include an IUD or a progestin implant that's placed under the skin. The chance of pregnancy with this form of contraception is less than 1 in 100. The chance of pregnancy with the typical birth control pill or progesterone pill is closer to 1 in 10. And condoms, although effective, the real world effectiveness yields a pregnancy rate of almost 1 in 5. And that's obviously because, well-intentioned though everyone may be, these last two forms of contraception depend on using them at the time of intercourse or taking a pill every day, whereas the long-acting reversible contraceptions are placed at one point and then patients don't have to think about it. So what one uses does make a difference in terms of risk of pregnancy. Next slide. The IUD is the most commonly used reversible method worldwide, although in the United States we don't use it so much. Next slide. And you can see that on the far right, the last time period that we could find data for was up to 2013. So presumably numbers are higher now, but patients using these long-acting reversible contraceptives, it was less than 10% of the U.S. Female population who were using contraceptives. And the poster on the left is something that was actually placed in subways as part of a campaign to increase awareness of the effectiveness of IUDs. And I thought it was sort of funny, but these were throughout the subway system for a period of time, just to try to educate women and make them aware of this as a safe and effective option. Next slide. So these long-acting reversible contraceptives are considered to be safe for young women, including adolescents and women who have not yet had children. And this is in contrast to the IUDs that were prevalent in the U.S. in the 70s and 80s. And in fact, the American Academy of Pediatrics recommends these as their first line of contraception for adolescents who are sexually active. Next slide. So how do we decide on what contraception to use for women with autoimmune diseases? Many forms are safe and effective, so we base it on the safety, the effectiveness, but also, of course, on the personal choice and preference for each individual patient. Some forms are not suggested for certain groups of patients. For example, estrogen-containing contraceptives should not be used by women who have positive antiphospholipid antibodies. These are antibodies that are associated with an increased risk of blood clot formation. Fortunately, they are very rare in patients with myositis, although they are common in lupus and seen in 1/3 of those patients. Next slide. In addition, other questions come up, and a common question has been, well, if one is placing a foreign object, is there a risk of infection associated with that in patients who are required to take immunosuppressive medicines? But no studies have suggested that to be the case. And in fact, there are specific studies that have looked at risk of infection in patients with HIV infection, and also in transplant patients who are on similar immunosuppressive medications to those that we use for our rheumatology patients. The progestin implant is placed under the skin in the upper inner arm, and it contains a progesterone compound, but it is fairly new, and we don't have any data for connective tissue disease patients. DMPA stands for depomedroxyprogesterone acetate, and these are injections that can be given every 3 months as a form of contraception, and they are pretty effective. However, they can increase risk of a decrease in bone density, and so patients who are on chronic corticosteroids or who have osteoporosis should avoid them. Next slide. And this is just a summary table of the things that we think about. So we try to use the most effective forms that are safe for the patient, and then we try to work with each patient in terms of what she is most comfortable with. I will point out one other thing that is here in red, which is that patients who are taking mycophenolate are asked to use either an IUD or two forms of contraception because of the concern that the mycophenolate can interact with estrogen or progesterone in combined oral contraceptives. That's something that, one's rheumatologist would usually mention, but good to be aware of. Next slide. Fertility. Next slide. These issues have become increasingly common as the technology and techniques have improved over the years. So infertility is defined as the inability of a couple practicing frequent intercourse, not using contraception, and not conceiving a child within 1 year. And it affects 20% of couples. And this is just a list of various factors, but a good number of patients or couples have unexplained infertility. This is what rheumatology and myositis patients are dealing with, that there is going to be some background level of infertility in the general population. And so having an autoimmune disorder is not going to protect against that, and in some cases can actually exacerbate that to some degree. Next slide. So family size is known to be reduced among patients with rheumatic diseases. Again, not specifically for myositis, but certainly in the more common diseases that have been studied, lupus and rheumatoid arthritis, patients have smaller families. And it isn't clear that this is related to any biological fertility problem. It's probably related to active disease, therapies that preclude pregnancy, impaired sexual function, personal choices. And we know, of course, there are some medicines that can impair fertility, the main one being cyclophosphamide. But in a survey of 114 women with lupus, a quarter of them viewed lupus as a barrier to childbearing. And another study from Italy showed that almost half reported great anxiety about pregnancy, and a quarter reported that lupus interfered with their ability to care for a family. All of these factors go into one's thinking and planning for pregnancy. Next slide. So there are different causes of infertility. I already mentioned just population as a whole. There is some baseline level of fertility difficulty for some couples. In addition, age is a very important factor for fertility in women, and there is an age-related fertility decline. And we think that patients who are advised to wait for quiet disease or to wait to become pregnant when they are no longer taking a teratogenic medication, obviously this pushes up their age at which they then do start to plan a pregnancy and a family. So it's particularly important for our rheumatology patients. Disease-related causes of infertility, not a big factor, although menstrual disturbances have been reported with active disease in lupus, but this is not felt to be a significant factor. I mentioned cyclophosphamide, the one medication that we use that can cause infertility. And infertility in the setting of cyclophosphamide is most common if a woman is older when she gets it and if she has a bigger dose, and it may affect males as well. Finally, prednisone can temporarily affect reproductive hormone feedback. And anti-inflammatory drugs can prevent eggs from being released at the time of ovulation, which is called luteinized unruptured follicle syndrome. So all of these factors can be at play depending on the circumstances for women with autoimmune disease. Next slide. Fertility in women with inflammatory myopathies has not been well studied. There were a couple of reports that I was able to find from the 80s. One showed an increase in nulliparity, meaning an increase in the number of women who never had children compared to the general population. And I think that all of the factors that we just talked about likely have a bearing on this. And then a possible reduction in the fertility rate. Again, many different factors, including decision-making about whether it is safe to have a pregnancy and whether one is capable of being healthy through the pregnancy and healthy after the pregnancy to care for the child. Next slide. So there are options for myositis, other connective tissue disease patients, just as there are for others in the general population. And one important one has been the fairly recent adoption of procedures to freeze eggs called oocyte cryopreservation that can later be thawed and fertilized with partner sperm to create embryos. It gives young women the option of biological children later. There are risks associated with it. The doctor has to stimulate the ovaries. That can cause high estrogen levels, that can cause flare in patients with lupus, and increase the risk of blood clots for any patient. But it is an option, and a good option, for stable patients who are concerned about age-related fertility issues. And then, of course, some patients will require IVF or in vitro fertilization for pregnancy. And it is a similar stimulation procedure for the ovaries with similar risks. However, from studies that have been published, again, mostly in patients with lupus, these procedures are generally well tolerated if patients are carefully followed and treated promptly if they develop any symptoms or side effects. Next slide. Now we get to pregnancy. With all the planning of either avoiding pregnancy or trying to become pregnant, now we're going to talk about the pregnancy itself. Next slide. So maternal and fetal outcomes in myositis pregnancies are probably affected by myositis, but not nearly to the same extent as in some other autoimmune diseases such as lupus and antiphospholipid antibody. However, there are still very small numbers of studies and small numbers of patients per study. Most of the reports are case reports, or what they call case series, a limited number of patients. Why is that? Well, there are a few reasons. Idiopathic inflammatory myositis is rare, and is rare compared to some of our other more common autoimmune disorders. In addition, it's diverse. So we have different types of inflammatory myositis, dermatomyositis, polymyositis, some overlap conditions. And then finally, there can be more variability in when the diagnosis is made, when the disease develops. So according to these studies, only 14% of patients with myositis develop disease before or during childbearing years. So we can look at this as in a couple of ways. One way to look at it is what happens if someone develops new onset disease during pregnancy. And the second is what happens in a patient with pre-existing disease who then becomes pregnant. Next slide. So this information is taken from a pretty comprehensive review of this literature from several years ago. And in general, I will tell you that overall, having new disease onset during pregnancy increases risk of poor pregnancy outcome. And in addition, having a flare of myositis during pregnancy also increases risk. If one is quiet at the time of conception and if disease remains quiet, that is, as one would imagine, the best in terms of optimizing pregnancy outcome, both for the mother and the baby. So the earlier during pregnancy that new onset disease comes, the greater the likelihood of losing the pregnancy. If it develops later during pregnancy, it seems not to have the same impact in terms of losing the pregnancy, although pregnancies may be delivered earlier than normal. And for patients with pre-existing myositis, roughly a half of them, of the 48 cases that were reviewed here, did have a flare during the pregnancy. But even with this significant rate of flare, there was only a single reported case of maternal mortality back in 1986, which occurred postpartum after successful delivery. And that's actually in marked contrast to some other autoimmune diseases like lupus, antiphospholipid, and vasculitis. Overall, women do well, but flare is important and should be treated promptly. Next slide. So as I mentioned, disease activity during pregnancy can increase the risk of adverse pregnancy outcome, and that can include loss of the pregnancy. And treatment during pregnancy, as well as quiet disease, is definitely associated with a much better outcome. Next slide. Neonatal outcome refers to the outcome for the baby. It's generally good, complicated primarily by complications that may come about with preterm delivery or a baby that's small for gestational age. Characteristic rash of dermatomyositis has not been described in any babies, and there was one report of an elevation in muscle enzyme levels, CK levels, in 2 newborns, but this was later felt to probably be passive transfer of these enzymes from the mother to the child. Next slide. There is a recent study published within the past few years that we call a big data study, similar to the study I mentioned before in contraception. This kind of study, again, looks at data in the computer and looks at what we call ICD coding, meaning the coding for different kinds of diagnoses. So what this group did was look at a large database looking at a number of hospitals across the country. That's called the Nationwide Inpatient Sample. And they looked for codes associated with myositis and with different pregnancy outcomes, including the length of stay, the development of high blood pressure, including preeclampsia and eclampsia, premature rupture of membranes, intrauterine growth restriction, which results in a smaller than expected baby, and also cesarean delivery. On their analysis, they found that myositis patients stayed in the hospital longer and did have an increased risk of hypertensive disorders, such as preeclampsia. But reassuringly, they didn't see an increase in the rate of premature rupture of membranes, small babies, or C-section. Next slide. Overall, we feel that the pre-pregnancy evaluation is really important for any patient with autoimmune disease or a rheumatologic disorder. First, disease damage can rarely make pregnancy unsafe for the mother. Fortunately, that's unusual in myositis patients, but could include severe lung fibrosis with heart manifestations. Disease activity is known to complicate pregnancy, and the recommendation is to treat and wait for quiet disease. Medications, of course, we talked about. There are only some medications that are safe for pregnancy, so meds may need to be changed. And then we do look at autoantibodies. Antiphospholipid antibodies are rare in myositis patients. Anti-Roux-en-Y antibodies can be associated with a neonatal lupus syndrome, but again, these are pretty rare in myositis patients and are much more common in lupus and Sjogren's syndrome. Next slide. This is a flow diagram just to give you a sense of how we think about pregnancy planning for patients with myositis. So as I mentioned, we want to assess the disease severity, the disease activity, the medications, the autoantibodies, all of the different factors that will impact whether or not now is a good time and a safe time for a patient to become pregnant. And once that is done, and this is really all done sort of simultaneously, then it gives the physician a chance to counsel the patient and her partner about any identified risks, any recommendations for monitoring or therapy changes, and delivery options during the upcoming planned pregnancy. Next slide. Medication use in pregnancy is a big issue. In the real world, pregnant and breastfeeding women are exposed to medications. First of all, only about half of pregnancies are planned, and about 90% of women take at least one medication during their pregnancy. That may be something as benign as Tylenol, but it's the majority of women. 50% take 3 to 4 medications during pregnancy. And women may need medication for pregnancy-induced symptoms, chronic conditions like autoimmune disease, or other infections, other conditions. There is overall a lack of good data on drug metabolism, drug transfer, and fetal effects because pregnant women are usually excluded from drug trials. And so even though that is completely understandable in terms of safety issues, it leaves us with a real lack of data in terms of safety for those women who do require medication during pregnancy. Another important issue is that sometimes fears regarding unknown teratogenicity or birth defect risk. These fears can be exaggerated, but not all fetal abnormalities are caused by drug exposure. There is a background rate of major birth defects that's 2 to 4%. And so it's important to remember that even without medication, these things can occur. Next slide. These are commonly used myositis medications. And as you can see, most medicines or many medicines are felt to be safe to use during pregnancy. Hydroxychloroquine, anti-inflammatories early, but not in the third trimester. Prednisone or prednisolone, very little of these steroids cross the placenta. Most of the steroid is inactivated by enzymes. Azathioprine is felt to be compatible with pregnancy. IVIG does cross the placenta, but is felt to be completely compatible with pregnancy. There are certain medications that are high risk and are to be avoided because of risk of birth defects, and those do include cyclophosphamide, mycophenolate, and methotrexate. And then rituximab can be used during pregnancy for severe disease. There is one study that suggested overall good outcomes, but is not used routinely during pregnancy. Next slide. We want to talk about breastfeeding also because breastfeeding is recommended by the American Academy of Pediatrics and has multiple benefits for both mother and baby. Next slide. Similar to medication use in pregnancy, many medications are felt to be compatible with breastfeeding, including many of those that I had just mentioned for pregnancy. So anti-inflammatories, prednisone, hydroxychloroquine, azathioprine, IVIG, rituximab is felt to be compatible with breastfeeding. And so if one requires that in an ongoing way, that is felt to be fine because very little of the IgGs cross into breast milk. And rituximab is a biologic medication that's based on an IgG construct. High-risk medications, the same three should be avoided: cyclophosphamide, mycophenolate, and methotrexate. Next. Menopause is an issue for all women, I think. Next slide. And until recent years, hormone replacement therapy was used very, very commonly. However, that has changed over the past 15 years or so when studies came out that showed that really we should limit use in healthy postmenopausal women using the lowest dose that alleviates symptoms for the minimum time necessary. And that's because these studies showed that the risks outweigh the benefits, and the risks include stroke and breast cancer. So the risks do depend on when you give hormone replacement therapy, what dose, what type, how long you use it. Benefit-risk balance is best for a woman who has severe vasomotor symptoms, such as hot flashes that really interfere with her ability to function or sleep, who are less than 60 or within 10 years of menopause onset. Next slide. So really, unless a woman has the antiphospholipid antibodies that I mentioned earlier that increase risk of blood clotting, patients can use this kind of hormone replacement therapy if it's felt to be necessary. Again, nowadays, it's a very small proportion of women. And then, according to recent studies, the transdermal estrogen, that is the HRT that comes in a patch rather than a pill, has less risk of side effects than the pill. And so doctors have been suggesting this as a first step if a woman requires hormone replacement therapy. Next slide. So in summary, the full spectrum of reproductive health is something that should be discussed periodically with your rheumatologist, including sexual health issues or concerns, contraception, fertility, pregnancy, breastfeeding, and menopause. And it is something that patients should be proactive about. if their doctor is not. We usually try to bring up these issues. For example, a young woman coming in for the first time, I will always bring up the question of contraception, obviously, especially if they're taking a medication that can be teratogenic. But if your doctor doesn't, it's important to think about and perhaps raise the question to him or to her, because this is an ongoing discussion between patient and physician, and between patient and rheumatologist, as well as patient and OBGYN, because really it's best if a team approach is used so that communication can help to establish what's best for any individual patient. I think I will finish there. I believe that's the last slide, and I'm happy to answer questions if there are any.
Thank you, Dr. Sammartino. We will now begin our question and answer session. As a reminder, participants can ask a question by typing it into the chat box located at the bottom of your screen. I will be helping to facilitate today's question and answer session. And to get things started, I will ask the question, what impact do hormone levels have on myositis symptoms? For example, are there changes in symptoms based on where a woman is in her cycle? What about during pregnancy? And what about during menopause?
At the risk of repeating myself yet again, there are so few studies on this in myositis patients. It really represents a big research need. Most studies have looked at either rheumatoid arthritis or lupus patients, and depending on the underlying diagnosis, it can make a difference. So many patients with lupus, for example, feel they have a flare during the week prior to their menses, and these patients are felt to be at greater risk for flare during pregnancy than other patients. Rheumatoid arthritis patients, on the other hand, typically can go into a remission during their pregnancy. Up to 50% of patients can stop their medication. So it certainly seems as though the interaction of reproductive hormones with the immune system and one's autoimmune disorder depends to some extent on the underlying diagnosis. There have not been any studies that have suggested a profound influence of hormones in patients with myositis, although I wouldn't be surprised if, individual patients reported noticing changes. But there's just not a lot of data.
Thank you. So we know that DM and PM patients are at greater risk for certain cancers, including breast and ovarian cancer. Can you talk about what is the connection between myositis and gynecologic cancers?
Well, I think that the connection really is between myositis and cancer. Not specifically, while reproductive cancers or gynecologic cancers are part of that spectrum, I think that it is not so much because they are gynecologic cancers as it is that there are certain forms of myositis with certain autoantibodies that tend to be associated with presence of cancer. I don't think it's specifically the reproductive hormones that are at play here.
Thank you. We have a question from a person who has who is JO1 positive. In 2004, she had a child with a congenital diaphragmatic hernia. She says she was not on any kind of medications at the time that could have caused this. She found a published paper on the condition that said maternal myositis is correlated with this. Have you heard about this before, and can you comment? And perhaps you can tell us what congenital diaphragmatic hernia is.
Well, that is where the diaphragm is inadequately developed and the contents of the abdomen protrude into the chest cavity. And I am by no means an expert on that, since it is, a pediatric neonatal condition. But I do think that there are situations where nowadays they can actually do surgical procedures on the developing embryo that can be helpful, but it is not always possible. I'm not aware of that paper, and I will have to look at that paper that associates myositis with this particular congenital abnormality. Although certainly I do believe that this is a variant of congenital abnormalities that's been seen across the spectrum in terms of the population. So I will have to look into it. I'm sorry I'm not familiar with that particular paper.
Thank you. Do you think, this question is from a patient, do you think myositis behaves more similarly to lupus or to rheumatoid arthritis?
Oh, I think to lupus. And that's just based on experience and the fact that, looking at that general literature review that I had in one of the slides, about half of patients were found to have a flare of disease during pregnancy, and that's very similar to lupus. So, and I think even in terms of the way we think about it, myositis patients, for example, are often treated with medications similar to those that are used for lupus. So I am more concerned about flare in a patient with myositis during pregnancy than I am in a patient with rheumatoid arthritis, where I'm just hoping that they actually have a remission and we can stop their medicine for part of the pregnancy. Having said that, I do think that for some important reasons, patients with myositis are at a lower risk of some of the serious complications that lupus patients get, because for lupus patients, very important factors in pregnancy risk are twofold. One, the presence of these antiphospholipid antibodies that can cause miscarriage or preterm delivery or preeclampsia. And the second is that, a third of lupus patients have underlying lupus involvement of the kidney, a history of some degree of nephritis. And having a history of nephritis is also a big risk factor for pregnancy, because a lot of stress is placed on the kidneys during the course of the pregnancy. It has to rev up. They have to rev up and they have to clear 50% more serum and blood than in the non-pregnant state. And so if someone has a little bit of kidney damage that normally doesn't impact them, it can become an issue during the course of a pregnancy where more stress is placed on the kidneys. So for those two reasons, even though I think of myositis as being more lupus-like, I would say that absolutely the risk of adverse outcome is less than for patients with lupus.
Thank you. And here's a question about myositis symptoms that started soon after a woman had a baby. Is there a relationship between that?
I'm not sure. We certainly see in rheumatoid arthritis, for example, a woman's greatest likelihood of developing RA is in the period after she's had a baby. And that may be because it goes down while she's pregnant, because remember I mentioned remission. That also means that women have a lower risk of developing the disease. I have not heard that there is an increased risk in the postpartum period, but I wouldn't be surprised, because the hormonal influences on the immune system are really incompletely understood. So when I see that, and I do sometimes see it with my patients, I'm not surprised, but I don't think it's been well studied. I'm not sure that there are studies that have found that.
Thank you. Is there any information on the new generation of biologics, for example, Xeljanz in pregnancy?
Well, so Xeljanz is a tofacitinib, and it is a new drug, and it is a small molecule. So it is not like rituximab, for example, that is a biologic drug that is basically an IgG antibody that has been manufactured in the lab to bind to CD20, the marker on immune cells that it targets. The reason that we look at them differently is that Biologic drugs that are based on an IgG structure are known to not pass through the placenta until about 16 weeks of pregnancy. And then by the end of the pregnancy, because naturally the placenta has receptors for IgG, so that when the baby is born, the baby has a lot of the mother's IgG antibodies. I mean, presumably as an initial period of protection until their immune system is up to speed. But this also means that if you give someone an IgG type biologic medication, the baby is born with high levels of that medication if it's continued throughout the pregnancy. Xeljanz is different. It's a very small molecule. We know that small molecules usually diffuse through the placenta quite easily. They don't need these special receptors. For this reason, we have hesitated to use them during pregnancy. You know, of course, there are always patients who must stay on a medicine or who inadvertently take a medicine, and that kind of information is always collected by the pharmaceutical company. But I think at this point in time, we do not recommend that type of drug for use during pregnancy or during breastfeeding for the same reason. It's a small molecule and it almost certainly will be transferred into breast milk.
Thank you. Can you clarify the significance of increased miscarriage risk in individuals with myositis?
So, increased miscarriage risk in patients with autoimmune disorders, we think of that as coming from a number of underlying issues. And probably the most important reason is the presence of antiphospholipid antibodies. So fortunately, myositis patients rarely have that. However, we do know that patients with active disease, and whether it's myositis or lupus or vasculitis, the presence of active severe flare of autoimmune disease can cause miscarriage. And so in the setting of miscarriage for myositis patients, I would think that would be the most common cause. And that is why I think that miscarriage is less common in patients with myositis than it is in patients with lupus, who have the added risk, or at least a third of them do, of these antiphospholipid antibodies that are responsible for many miscarriages.
Thank you. So do you recommend for someone who is having trouble with getting pregnant, do you recommend infertility treatments such as IVF?
Absolutely. You know, the only additional recommendations for patients with myositis, as opposed to someone in the general population considering IVF or other, you know, they call it assisted reproductive technology now, because sometimes women can become pregnant with just the addition of certain medications. But I think for patients with myositis, it's important to think about undergoing IVF or fertility treatments as though planning a pregnancy, obviously. So it's important to do that at a time when the disease is quiet. And then the other thing to think about is that it's important to do that at a time when one is on medications that are compatible with pregnancy. The exception to that, which I had pointed out, was if someone, a different situation, a woman is not trying to get pregnant and having difficulty, but she's 33 years old and she wants to freeze her eggs. In that situation, because she's not carrying a pregnancy right then, she can stay on whatever medicine she is on that are controlling her disease and go through with the egg retrieval and egg freezing process. But when the goal of the procedure is pregnancy, obviously, all of those things I mentioned about planning pregnancy and timing it and adjusting medications, those all need to be attended to prior to going through IVF.
Thank you. I think that seems to be the end of our questions. Are there any additional questions out there? Oh, here we go. I was diagnosed with dermatomyositis in 2017, and after getting most of the disease under control, became pregnant in January of 2019. I'm currently at 28 weeks, and all is normal besides some skin flares. I'm wondering if there is any research about how likely it is that the disease will flare and return fully after delivery.
There really is not much information about that. And it comes down to, again, sort of this postpartum flare. Very common in rheumatoid arthritis, common in lupus, certainly happens in myositis, but I don't think we have enough data to say how likely it is to get into numbers. But I think that, one thing that we've learned is that even when we're not able to project certain likelihoods, when we know that something is a possibility, it's just very helpful to be carefully followed by the rheumatologist throughout the pregnancy and the postpartum period, because if something starts flaring, you want to catch it early, because that is a way of minimizing the impact of a flare. Whereas if one goes home and doesn't come in for a follow-up for 6 months during the postpartum period, that can allow things to get out of control if one's not aware of it. And, let's face it, when a woman is postpartum, she doesn't feel back to normal yet. So it can be really hard to know whether there's a flare or whether it's lack of sleep or whether, it's this whole new experience of caring for a newborn. So I think that while we aren't able at this time to give percentages, we can say that careful follow-up means that flares will be identified early and should be, aggressively, quickly treated, and that will improve outcomes.
Thank you. Again, there are no more questions in our queue. If anybody has one and they want to quickly send that along, we would be happy to have that answered. If not, then perhaps we should move on to the next slide. And this concludes our webinar. Thank you again to Dr. Sammartino for this very informative presentation. And thank you to all of those of you who joined us for today's webinar, Reproductive Health in Myositis and Other Autoimmune Diseases. Please visit www.myositis.org, where you can learn more about myositis diseases. Be sure to sign up as a member of TMA to receive our print and email newsletters and to learn about other educational opportunities like this one. We also ask you to please provide your feedback on this webinar by completing our short survey that you will find in your email after this webinar. Next slide, please. Again, it's not too late to register for TMA's annual patient conference. This is an excellent opportunity to hear lots more informative presentations like this one, and it's also a great place to meet more than 400 others who live with myositis and their family members. Next slide. Thank you very much for attending.